Welcome to the RSNA Radiographics Podcast. My name is Sudeep Soni, and I am a body radiologist for the Community Radiology Division of Johns Hopkins. Today, we're discussing an important evolution in liver MRI, dual contrast agent imaging for focal liver lesion characterization, based on a 2026 radiographics article by Dr. Anup Shetty from the Mallinckrodt Institute of Radiology and colleagues. Focal liver lesions are incredibly common, present in at least 15% of the population, and while many are benign, diagnostic uncertainty can lead to repeat imaging, unnecessary biopsies, increased cost, and significant patient anxiety. Traditionally, radiologists choose either an extracellular agent or a hepatobiliary agent, each with its distinct strengths and equally important distinct limitations. The central message of today's article is simple but powerful. Using the wrong contrast agent at the initial MRI can compromise diagnostic accuracy. The authors propose a solution, a sequential dual contrast agent MRI protocol that combines the advantages of both agents in a single examination. Over the next 15 minutes, we will review why this matters, how the protocol works, and when it meaningfully changes patient care. Let's start by discussing why contrast choice matters. Dynamic contrast enhancement is one of the most critical components of liver MRI interpretation. The enhancement pattern, and particularly during arterial, porovenous, delayed, and hepatobiliary phases, often determines whether lesions can be confidently classified as benign or malignant. However, not all gadolinium-based contrast agents behave the same way. Broadly, liver MRI contrast agents fall into three categories. First, extracellular agents, or ECAs. Second, hepatobiliary agents, or HBAs, most commonly gadoxetate, and third, hybrid agents, such as gadobenate. Each of these agents interrogates a different aspect of lesion biology. ECAs highlight vascular behavior, HBAs provide functional information about hepatocyte uptake. Hybrid agents attempt to combine both, but with important trade-offs. The key challenge is that no single agent excels across all diagnostic tasks, and choosing the wrong one at the outset can limit diagnostic confidence. Single contrast imaging has its limitations. Extracellular agents alone are excellent for evaluating vascular enhancement patterns. They reliably depict arterial hyperenhancement, washout, delayed enhancement, and capsular appearance. This makes them particularly useful for diagnosing hemangiomas and assessing washout and suspected malignancy. However, extracellular agents do not provide a hepatobiliary phase. Without hepatocyte uptake, it can be extremely difficult to distinguish focal nodular hyperplasia from hepatic adenoma, a distinction that has real clinical implications. Prior studies have shown that diagnostic accuracy for these lesions improves dramatically from roughly 50 to 70% with ECAs alone to over 95% when hepatobiliary imaging is included. Additionally, ECAs are less sensitive than hepatobiliary agents for detecting small metastases, particularly in patients undergoing oncologic staging. Hepatobiliary agents such as gadoxetate offer high sensitivity for detecting hepatocyte-deficient lesions and provide a robust hepatobiliary phase at around 20 minutes. They are especially valuable for detecting small liver metastases and characterizing lesions based on hepatocyte function. However, gadoxetate-based imaging has several well-recognized limitations. First, the transient arterial phase motion that occurs in up to 20% of patients can severely degrade arterial phase image quality. This can obscure the non-rim arterial phase hyperenhancement needed for characterization of a liver observation as definitive hepatocellular carcinoma using the LIRADS criteria, or the peripheral nodular discontinuous enhancement characteristic of a cavernous hemangioma. Second, when using gadoxetate, there's effectively only one valid phase, the porovenous phase, for assessing washout, because hepatocyte uptake begins shortly thereafter and can induce lesional de-enhancement rather than true washout. Third, the approved dose of gadoxetate is about a quarter of the standard extracellular agent dosing, resulting in a weaker arterial enhancement unless off-label double dosing is used. And perhaps most importantly, some benign lesions may demonstrate atypical or misleading enhancement patterns with gadoxetate. For example, some hemangiomas may not exhibit progressive centripetal enhancement with gadoxetate and may appear to wash out, leading to a discrepancy with other imaging features and diagnostic confusion. Hybrid agents, such as gadobenate, should offer the best of both worlds, combining the benefits of extracellular agents and hepatobiliary agents. But in practice, they introduce new challenges. For example, the hepatobiliary phase offered by gadobenate requires a much longer delay, requiring at least 1 hour of imaging compared with 20 minutes after gadoxetate. This reduces scanner efficiency since patients would have to remain in the scanner for a longer period of time to obtain this hepatobiliary phase imaging, and it prevents other patients from undergoing imaging. Also, the hepatocyte uptake for hybrid agents is relatively weaker, resulting in less contrast between the background liver and the focal liver lesion. Finally, the interstitial or intravascular persistence of the contrast agent in a patient with poor blood pool clearance may result in perceptual errors and mischaracterization. For example, a cavernous hemangioma retaining contrast during hepatobiliary phase imaging, which can result in mischaracterization as focal nodular hyperplasia. Given these limitations, the authors of the article propose a straightforward but highly effective solution. Use both agents sequentially in the same examination. This captures the strength of both extracellular agents and hepatobiliary agents for more definitive initial liver lesion characterization. This also facilitates efficiency in MRI scheduling and the potential errors that come with choosing the wrong contrast agent. The dual contrast protocol begins with an extracellular agent to optimize arterial, portovenous, and delayed phase imaging, which ensures reliable assessment of enhancement kinetics, washout, and capsular features, without the risk of arterial phase degradation that comes with hepatobiliary agents. A hepatobiliary agent, specifically gadoxetate, is then administered later in the exam to allow functional characterization of focal liver lesions and improve sensitivity for detection of liver metastases, as well as lowering the risk of inadequate blood pool clearance that can be seen with hybrid agents. After the initial dual contrast agent liver MRI protocol, follow-up MRI examinations may use a single contrast agent tailored to the imaging findings from the initial study. So how exactly does this dual contrast protocol work? First, all sequences in which the signal and intensity would be altered by contrast agents are performed, including T1-weighted chemical shift imaging and T1-weighted pre-contrast imaging. Then, the extracellular agent is administered at standard dosing, and dynamic imaging is performed through the arterial, portovenous, equilibrium, and delayed phases. Next, the hepatobiliary agent is administered at the standard dose. Remember, the off-label double dosing is not required with the dual agent protocol, since we are simply using the hepatobiliary agent for high-quality hepatobiliary phase images, and we no longer need to optimize the dynamic phases of contrast enhancement. This results in a total dose of gadolinium that is only 25% more than a routine extracellular agent study. The administration of the hepatobiliary agent starts the clock for the 20-minute hepatobiliary phase, the primary rate-limiting step for hepatobiliary imaging in liver MRI. To maximize efficiency, this period can be used to obtain the sequences that can be performed post-contrast, such as T2-weighted imaging and diffusion-weighted sequences. And finally, the hepatobiliary phase imaging is obtained at approximately 20 minutes after gadoxetate administration. The total examination time is about 40 minutes, which is longer than a single-agent study, but significantly shorter than a hybrid agent protocol that requires about 1 hour delay. Acquisition times can be further shortened on more modern MRI units equipped with advanced acceleration techniques. The article offers several case examples clearly demonstrating where dual contrast imaging makes a meaningful difference. In one example, utilizing a hybrid agent in the setting of poor blood pool clearance, multiple liver lesions were incompletely characterized as focal nodular hyperplasia due to retained contrast at hepatobiliary phase imaging. This case led to the development of the institution's dual contrast agent protocol, with subsequent imaging showing unequivocal hepatobiliary phase hypointensity and correctly diagnosing these lesions as hepatic adenomas. In other cases, dual contrast imaging enabled a confident differentiation between hemangiomas and metastases, avoiding diagnostic ambiguity that could have led to unnecessary biopsy or follow-up imaging. Overall, the protocol improves diagnostic confidence, accuracy, and downstream clinical decision-making. The authors appropriately acknowledge several limitations that come with the dual agent protocol. As mentioned previously, the total gadolinium dose is modestly increased, about 25% higher than an ECA-only study, though this may be justified by its greater diagnostic confidence for characterizing focal liver lesions. Once a lesion is characterized, however, follow-up studies generally do not require the dual contrast agent protocol. Secondly, the proposed dual contrast agent protocol uses the single standard dose of gadoxetate rather than the double dose that can be used off-label. This can result in a weaker hepatobiliary phase, resulting in less conspicuous hepatobiliary phase uptake in lesions and/or the background parenchyma. Finally, the examination is somewhat longer than single-agent studies. However, it is significantly shorter than the hybrid agent protocol that was previously used for characterization of these indeterminate liver lesions at the author's institution and provides better hepatobiliary phase contrast. And again, follow-up imaging typically requires only a single contrast agent. Importantly, the dual contrast agent protocol may be of increasing utility if future iterations of the LIRADS criteria incorporates hepatobiliary phase hypointensity as a critical feature. In patients with advanced liver disease in whom the liver parenchyma uptake may be impaired, using an ECA in a dual contrast agent protocol improves the likelihood of a high-quality arterial phase. I'd like to close by thanking the authors, Dr. Shetty and colleagues, for an excellent and clinically impactful article that thoughtfully addresses a very common and often challenging problem in liver imaging. For listeners who would like to explore this topic further, I encourage you to visit the Radiographics website to read the full article and to check out the many other outstanding educational reviews and research articles published there. If you found this episode helpful, please take a moment to rate, review, and subscribe to the RSNA Radiographics podcast. Your feedback helps others find our shows and allows us to continue expanding the reach of this educational content. And finally, thank you for joining me for this podcast. I appreciate you taking the time to listen, and I look forward to sharing more radiology education with you in future episodes.